Hello, everyone. So this is Dr. Madhusudan Rao, retired professor and HOD of pediatrics. On the program, I teach medical students. Well, again, this lecture is meant for the first year MBA students who have just entered the clinical arena. Today, in this class, we are going to touch upon the topic that is auscultation of heart, part 2. In part 1, we have dealt with the heart sounds, including the basics of cardiac cycle. In this class, we are going to talk about the murmurs. Murmurs. So we got to have the knowledge of the timing of the murmurs, and whenever of the patient, how you have got to examine, and various features of the murmur with regard to the pitch, loudness, quality, etc. And also take the associated symptoms and clinical signs into consideration in order to make the provisional diagnosis. Your diagnosis should be supported by electrocardiogram and X-ray chest, and it should be confirmed by echocardiography. Say, for example, you appreciate a pansystolic murmur at the left lower sternal edge with precardial bulge, etc. You think your provisional, and there are symptoms of recurrent cough and features of congestive heart failure with regard like exertion dyspnea, etc. You think your provisional diagnosis is a ventricular septal defect, and it should be supported by ECG and X-ray chest and should be confirmed by echocardiography. These tools of evaluation are so important in order to help assist you to improve your knowledge, in order to confirm your clinical signs and your provisional diagnosis. That's how you will be able to step up your knowledge by improving your clinical skills in order to elicit the murmurs in cardiac auscultation. So let us proceed how to do about it. You try to describe the murmur. Try to time the murmur, whether it is systolic or diastolic. How do you time the murmur? First, you have to identify the first heart sound. How do you identify the first heart sound? First heart sound corresponds to the apical impulse. You keep your stethoscope on the chest of the patient, and with one of the fingers, you palpate the apical impulse. The sound that corresponds to the apical impulse is the first heart sound. You also correlate the sound with the carotid pulsations. The carotid pulse that corresponds to the sound is the systolic, and that is the first heart sound. Once you made out the first heart sound, the period following the first heart sound is systolic period. Okay, the other one is the second heart sound. The phase of the cardiac cycle following the second heart sound is the diastolic phase. So based on this, once you identify the first heart sound, you can time the murmur, whether it is systolic or diastolic. Area, where site on the pericardium where it is best heard. When the murmur is heard best at the apical impulse, or best heard at the left lower sternal edge, or best heard at the left upper sternal border, or right second space, or the carotids. So each area corresponds to the part of the heart or the location of the valves that you are auscultating. Okay, apical impulse corresponds to the area of mitral valve, and left upper sternal border, left second space corresponds to the events that occur across the pulmonic valve. The area that is right up second space or left third space, the parasternal area, corresponds to the aortic area. And the left lower sternal edge or epigastrium corresponds to the tricuspid area, tricuspid valve. The events in these locations will speak about the area where the murmur is generated and the pathology down there. So area of the site of maximum loudness of the murmur should be picked up while auscultating the murmurs. Loudness, it is based upon the frequency. Based on the loudness, you are going to grade the murmurs. Character, is it soft or harsh? Pitch, which depends upon the velocity of flow and gradient across the valve. Lower the gradient, lower the pitch. Higher the gradient, higher the pitch. Radiation, it means the conduction of the murmur from the site where you are able to locate to the different area with the same intensity is called radiation. Whenever you are able to appreciate the murmur. If the murmur is heard in the lying down posture, and if it disappears while standing posture, that is innocent murmur. And changing with the respiration. The murmurs on the right side will be increased in intensity or better heard during inspiration, and the murmurs on the left side, they will be more appreciated in the face of expiration. And the features of the murmur, the student can remember this particular acronym to describe the features of the murmur. You look into the acronym, that is script. S stands for site where the murmur is heard best. C stands for character, whether it is soft, rough, blowing, crescendo, or decrescendo. Radiation, conduction of the murmur with the same intensity to axilla or to carotids, etc. I stands for intensity, that's the loudness, based on which you are going to grade the murmur. Grade 1 is the murmur which is barely heard. Grade 2 is clear, heard, but not that clear. And grade 3 is clearly heard murmur, but no thrill. Grade 4 is the murmur that is clearly heard with the presence of thrill. Grade 5 is easily and clearly heard. It is even heard the stethoscope barely touching the chest wall. And grade 6, the loudness of the murmur that you can appreciate even when you keep the stethoscope away from the chest wall. This is how the grading of the murmur is heard. Most of the time you appreciate the murmurs around grade 4. Timing, T stands for timing, whether it is systolic, diastolic, or continuous. So these are the important points that you have got to describe the murmur using this acronym script. It's easy to remember. Coming to systolic murmurs. Systolic murmurs could be physiological, which are called normal. Pathological, also called organic or abnormal. Systolic murmur could be early systolic, mid systolic, late systolic, or pan-systolic. Okay, it could be ejection murmur or regurgitant murmur or shunt murmur. Okay, ejection murmurs. The turbulence flow across a narrowed or normal wall. Then during the systole is called ejection murmur. The ejection murmurs are characteristic feature of aortic and pulmonary valve stenosis. They are usually mid-systolic, have crescendo and decrescendo character. Okay, that is, crescendo means ascending degree of intensity, and the decrescendo is when decreasing loudness. Severity stenosis is more, murmur is harsh and longer. Okay, if the stenosis is severe with the intact interventricular septum, the murmur becomes more harsh and longer. And it increases in crescendo phase and decreases in decrescendo phase. This is the pictorial representation of the systolic murmurs. See the mid-systolic in nature. It is crescendo, decrescendo in quality. Start with the first harsh sound, ends just before the second harsh sound. There is ejection click following the first harsh sound, especially in valvular stenosis. This is the pansystolic murmur. Starts with the first harsh sound, continues with the same intensity. There is no crescendo, decrescendo of quality. Ends with the second harsh sound. The pansystolic murmur is a characteristic feature of mitral regurgitation and ventricular septal defect. Regurgitated murmurs, they are due to retrograde flow of blood. That is, if the blood is flowing from the left ventricle to the left atrium, it is retrograde. That occurs in mitral regurgitation. The pansystolic in nature, louder and harsh. Okay, sometimes it could be softer, less louder if it is associated with severe incompetence. At times, they could be late systolic, usually in mitral valve collapse. Still's murmur is a benign murmur. It is mid-systolic. Okay. Usually around grade 3 or just grade 3. So they are the diagrammatic representation of the sonography of the various murmurs. So it is aortic stenosis, it is crescendo, decrescendo murmur, ejection systolic, mitral regurgitation is the pansystolic murmur, low pitched, aortic regurgitation, early diastolic murmur, mitral stenosis associated with the mid-diastolic murmur with pre-systolic accentuation. This is a continuous murmur, systolo-diastolic, feature of patent ductus arteriosus. Coming to the diastolic murmurs, they could be early diastolic, mid-diastolic, or late diastolic. They are always pathological. Graham-Steele murmur. What is Graham-Steele murmur? It is early diastolic murmur heard in patients with pulmonary hypertension. It is described today. It is used to describe the early diastolic murmur in pulmonary area in patients with pulmonary mitral stenosis. Caricum's murmur or Coombs murmur is a clinical sign which occurs in patients with mitral valvulitis due to acute rheumatic fever. It is described as a short mid-diastolic rumble, vested at the apex, which disappears as the valvulitis improves. Once you keep the patients on steroids, the inflammatory phenomena disappears and the murmur becomes less prominent, ultimately disappears. It is often associated with the S3 gallop and can be distinguished from diastolic murmur of mitral stenosis by the absence of opening snap before the murmur. See, this is the functional murmur. Because of the edema of the mitral valve or the ring, there is narrowing of the mitral valve orifice that results in the mid-diastolic murmur without pre-systolic accentuation. This is because the increased blood flow across the thickened mitral valve. And this disappears once the edema subsides with steroids. This is the Carey-Coombs murmur. It's simply a low-pitched murmur heard in the mid-diastole without pre-systolic accentuation. There is no opening snap. Okay. This disappears with the treatment. Austin Flint murmur. Austin Flint murmur again a metastatic murmur. Okay. Heard in patients with severe aortic regurgitation. Because there is impinging of the regurgitation jet on the anterior leaflet of the mitral valve, thereby causing the obstruction to the flow of blood from the left atrium to the left atrium ventricle during diastole. Then turbulence is generated in the narrowed mitral valve, resulting in mid-diastolic murmur. This is named as Austin Flint murmur. They simply said is a mid-diastolic murmur in patients with severe aortic regurgitation, heard at the mitral area. Coming to the shunt murmurs, they are murmurs generated due to the flow down the gradient. They are at the site of the shunt or away from the location of the shunt. Say this is the mid-diastolic murmur, systolic murmur. That is shunt murmur, you can say, with the fixed, wide fixed splitting of the second heart sound. So this soft, low-pitched, blowing systolic murmur is heard in right upper sternal edge, that is pulmonic area, with the fixed, wide splitting of the second sound. What is the diagnosis? It is atrial septal defect. Murmur is heard because of the increased flow of the blood across the pulmonic wall, which is normal. So this is the murmur heard away from the site of the shunt. Look at these diagrams. So today, this is the typical ventricular septal defect murmur. The pansystolic murmur starts with the first heart sound, ends with the second heart sound, and P2 is normal, and the split is normal. Second sound split is normal. Okay, this is the typical VSD without pulmonary arterial hypertension. This is membranous or perimembranous form of ventricular septal defect. This is the muscular VSD. The characteristic feature of the muscular VSD is systolic murmur, okay, which is with the decreasing nature and stops short of the second heart sound, okay, and P2 is normal. Ventricular septal defect with mild pulmonary stenosis. See, here there is pansystolic murmur, P2 is heard later than the aortic component of the second heart sound. There is a little more gap between the A2 and P2 because of the delayed closure of the pulmonic valve due to pulmonary stenosis. Here is the VSD with severe PS. Severe PS is associated with the diminished intensity of the P2, and there is VSD with severe PS. PS is associated with crescendo decrescendo murmur. It dominates the murmur of VSD. VSD with Eisenmenger complex. Once there is an Eisenmenger phenomenon is set in, pansystolic murmur disappears. There is a merging of the P2 and A2 with loud thudding second heart sound with presence of early diastolic murmur of pulmonic regurgitation. This is the VSD with AR. There is pansystolic murmur of shunt VSD with early diastolic murmur of aortic regurgitation. And both the components of the second heart sound are clearly heard. Whereas in PDA, Gibson's murmur, it's a continuous murmur with the murmur overlapping the second heart sound. The peak of the murmur is around this S2. Continuous murmurs are always pathological. Diastolic component decreases with increase in the pulmonary pressure. Murmur disappears when the pulmonary and systemic pressures are equal. Okay, this is the dictum. Pericardial rubs. There are high-pitched scratching sounds. Systolic, diastolic, and systolic. It's triphasic sounds. This is because of the rubbing of the inflamed layers of the pericardium. Best heard in sitting and leaning forward positions. What is the importance of appreciating the murmurs in a patient? Patients come to you and he will say that somebody has told me that I've got my son or my daughter has congenital heart disease. Mother says that one of the doctors whom I consulted, they said, my child's heart has got a hole inside. I don't know what is the hole and where is the hole. They mean that there is a congenital heart disease that is diagnosed by some of the doctors whom she consulted. So it is up to you to appreciate the murmur in order to exclude functional murmurs, identify organic murmurs. Okay. In the light of the supporting history and other clinical signs, confirm the diagnosis, do the counseling with the parent in order to undertake appropriate treatment. So what are the red flag signs of a murmur? They include 1, if it is holosystolic murmur, if it is diastolic murmur, associated with abnormal second heart sound, associated with grade 3 or higher, harsh in quality, there is presence of clicks, murmur in left upper sternal border, which gets increased in intensity when the patient is in standing posture. Okay. If you appreciate the systolic murmur at the left second space, in lying down posture, make the patient to stand up and auscultate for the same event. If the murmur is getting intensified or persistent, it is pathological. If it disappears, it is physiological. If you look into the basics of the cardiovascular system, blood flows is pulsatile. It is the result of contraction and relaxation of the ventricles. The movement of the tissues, closure and opening of the valves, pressure changes result in the direction of blood flow and loudness of the sounds. First and second sounds without a murmur is normal and healthy heart. Innocent murmurs are mid-systolic, upper right or mid-sternal border, low intensity less than grade 3, no associated symptoms, decrease or disappear in standing posture. So all others are pathological murmurs. There are 7 S's to define innocent murmur. These are the key features of innocent murmur. 7 S's, remember. Number 1, short, not holosystolic, soft, low amplitude, small, limited to a small area, sensitive, changes with position, single, not associated with clicks, sweet, not harsh sounding, sweet murmur, systolic, occurs during and limited to systole. Well, thank you very much for patient listening, my dear students. Remember these important points that I described in the murmurs. Apply them while examining the patient or the auscultating the heart. So wish you all the best to apply these skills and arrive at the provided diagnosis of the cardiac lesion. Thank you very much for patient listening. I'll meet you again in the next class. Until that time, bye-bye.